Good evening, everybody. I'm Dr. Nishtha Gupta Neja.
Ma'am,
Today we'll. Ji?
I'll just give an introduction about you to everyone, ma'am, so that they'll have a brief on you, and then we can
Okay,
start the
perfect.
presentation.
That works.
Yeah.
Okay.
Good evening, everyone. This is Mr. Vyas here. Can everybody see the slides?
Yes, visible, sir. Visible, very visible.
Yeah. Thank you so much. So I welcome Dr. Nishtha Gupta here, and it is our honor to host this program. And she is an MBBS and MBBS MD psychiatry, and she has got certification in perinatal psychiatry from NIMHANS, Bangalore. And she is a certified in brain stimulation from Medical University of South California, USA, a diploma in hypnotherapy. She has 19 international publications, including the WHO COVID and mental health database. She has represented India in 2021 World Psychiatric Association held in Germany. BC Borley Award winner for the best paper presentation in Industrial Psychiatry Association for India in 2022, awarded by Government of Maharashtra for active work towards betterment of industrial workers during the pandemic of 2021, and she is awarded with Women Leadership Award in Health Sector 2022 by International Women Congress. It's our honor and privilege to welcome you here today, ma'am. Please take on the stage.
Thank you. I will just share the screen. My screen is visible now.
Yes, ma'am. Your screen is visible, and you're audible.
Great, great. So we will start with straight away start with the presentation. Thank you so much for such a great introduction. And ADHD, as we all know, is attention deficit hyperactivity disorder. So we will begin with the biology of ADHD. In the biology of ADHD, we talk about the symptoms of ADHD. Basically, what are they? So when we talk of ADHD, two things are there in the name itself. One is hyperactivity, and the second is inattention. The third thing that we do not talk about much is the impulsivity that children or people with ADHD have. So in the biology of ADHD, we look at the hyperactivity, which is because of the effect on the prefrontal motor cortex. The second is inattention. Inattention is again of two types: selective inattention, problem in selective attention, and problem in sustained attention and problem solving. When we talk of selective attention problem, the problem is basically in dorsal anterior cingulate cortex. And when we talk of sustained attention and problem solving, it is the dysfunction is in DLPFC, that is dorsolateral prefrontal cortex. The last thing that we talk of is impulsivity. And when we talk of impulsivity, the disorder or the biology lies in the orbitofrontal cortex. After the biology, the second thing that we talk about is that whatever symptoms we have are due to some dysfunction in the circuits present in the brain. And while I read out the circuits, you will be able to pinpoint with the arrows. So the first circuit is that there is failure of inactivation in the CSTC loop. CSTC is corticostriamothalamocortical loop, which we all know that this loop is also involved in OCD. But in CSTC loop, there are three main dysfunctions. The first is the dorsolateral prefrontal cortex that connects to the striatum, that connects to the thalamus, which again connects to the DLPFC. So it is DLPFC, striatum, and thalamic loop. Because of this, there is lack of attention and arousal, which leads to difficulty in following through or finishing tasks. बच्चा काम शुरू तो कर देता है, but finishing the tasks is a big problem. Organizational tasks or sustaining mental effort is a big problem for the child. The second loop is dorsal anterior cingulate cortex, that is dorsal ACC, striatum, and thalamus. Problem in this leads to inattention. When we talk of inattention, it is the inability to give attention to details. The child makes careless mistakes, not listening, getting easily distracted, forgetting things, losing things, forgetting a pencil or a pencil box in school, forgetting their tiffin box in school repeatedly. The third loop is the orbitofrontal cortex, that is the OFC. And the loop that is affected is OFC, that connects to striatum and thalamus. This leads to excessive talking, blurts out answer, cannot wait for their turns, and often interrupts others. Another loop that is involved is the prefrontal motor cortex. Now, the loop is the prefrontal motor cortex that connects to the striatum and thalamus. This leads to the child being fidgety. They cannot sit in one place. They cannot play quietly. And the child keeps on running around, keeps on climbing on the chairs, climbing on the tables, and so on. So these are the four circuits involved in ADHD. When we talk of the diagnosis of ADHD, now we all know that earlier we were using ICD-10. In India, we were following the diagnostic criteria of ICD-10, but now we have a revised function, ICD-11, and we have started following that. So in ICD-11, what has happened is that attention deficit hyperactivity disorder is now of different types. The first is persistent inattention type. The second is hyperactive impulsive presentation. The third is combined presentation. And the fourth is other specified and unspecified presentations, which are hardly the diagnosis. So it is mostly predominantly inattentive type, hyperactive impulsive type, or combined type. One change that the DSM-5 has made, usually for diagnosis in India, we do not follow the DSM-5. Legally, we follow the ICD-11, but we need to know the recent changes. So in recent changes, whereas in the past, ADHD symptoms had to be present by the age of 7 years, in DSM-5, several inattentive or hyperactive impulsive symptoms must be present by the age of 12 years. So from 7 years, they have increased the age to 12 years. Previously, there was two subtypes. Those were inattentive and hyperactive, impulsive type. Now, however, in DSM-5 as well, they have been replaced by the following three specifiers. The first is combined presentation, which is the most common. The second is predominantly inattentive presentation, which is the second most common. And the third is predominantly hyperactive impulsive presentation. So DSM-5 has also made these changes. Now, when we talk of symptoms and diagnostic criteria for us clinicians, it is very important to know what are the diagnostic criteria for ADHD. So in ADHD, there has to be a persistent pattern of inattention and or hyperactivity and impulsivity that interferes with the functioning or the development as characterized by, one out of inattention and hyperactivity. So what has to be there is that there has to be persistent pattern of inattention and or hyperactivity and impulsivity. Now, when we talk of inattention, the first thing is inattention. Now, when we talk of inattention, 6 out of these 9 criteria should be present for more than or equal to 6 months. So out of these 9, the 9 ones that are listed over here, out of inattention, 6 have to be present for more than or equal to 6 months. Now, what is inattention? The first is child often fails to give close attention to details or makes careless mistakes in schoolwork. Second, often have difficulty in sustaining attention or in tasks or in playing activities. The third is often doesn't seem to listen, but just sunta nahi hai when spoken to directly. Next, often doesn't follow instructions or fails to finish schoolwork or duties in their workplace. The other is often has difficulty in organizing tasks and activities. The child often avoids or dislikes or is reluctant to engage in tasks that require sustained mental effort. Eighth is often loses things necessary for tasks or often easily distracted by external stimuli. And last is they are forgetful in their daily activities. The second is hyperactivity. Now, again, 6 out of these 9 symptoms should be present for us to label that the child is hyperactive, and they should also be present for equal to or more than 6 months. So for hyperactivity, the 9 symptoms that are present are, first is often fidgets or taps their hands and feet. So the child is very fidgety. The second is they often leave their seat when they are expected to be seated. Third is they often run about or climb in situations where it is inappropriate. जब उनको रेस्टोरेंट लेके जाते हैं, बाहर लेके जाते हैं, डॉक्टर के केबिन में बैठे होते हैं, तो वो चेयर्स पे टेबल्स पे चढ़ना शुरू कर देते हैं, एक जगह बैठते नहीं है. नेक्स्ट इज दे आर ऑफन अनेबल टू प्ले क्वाइटली. एक बहुत कॉमन कंप्लेन है which is also in the diagnostic criteria is it seems as if the child is driven by a motor or is always on the go. They talk excessively, often blurt out answers. Eighth is that they have difficulty in waiting for their turn. And the last is they often interrupt or intrude others in order to tell what they want to say. So these were the two symptoms: inattention and hyperactivity. 6 out of 9 should be present for us to label that the child is either inattentive or hyperactive, and they should be present for at least equal to or more than 6 months. In the diagnostic criteria, the other criterias are, the third is that the onset should be less than 12 years. Now we will follow the DSM guidelines in this, as DSM has raised the age from 7 to 12 years. They should be present in at least two settings. ऐसा नहीं है that the child is only having all of these troubles at home. It is usually for children, it is home and school. So they should be present in at least two settings, in home and school. They lead to significant dysfunction in the child's life, and they are not explained by any other psychiatric disorders. Now, what are the differential diagnoses of ADHD? There is a temperamental constellation of high activity level and short attention span in the normal range for child's age. Children are not that attentive and they have a little more energy. And without impairment, this should also be ruled out according to the child's age. It is critical to evaluate for anxiety. Anxiety can accompany ADHD as a symptom or as comorbid disorder and can also manifest with overactivity and easy distractibility. So that has to be ruled out. The next is that it is not uncommon for a child with ADHD to become demoralized or in some cases to develop depressive symptoms because oftentimes they are not able to express themselves and they become aloof. That is why they become demoralized. So they develop depressive symptoms in reaction to persistent frustration with academic difficulties, resulting in low self-esteem. So depression should always be ruled out. And mania and ADHD, although it is not very common in children, but mania and ADHD share many core features, such as excessive verbalization, motor hyperactivity, high levels of distractibility. Also in children with mania, irritability seems to be more common than euphoria, which is seen in adults. Although mania and ADHD can coexist, children with bipolar 1 disorder exhibit more waxing and waning symptoms than those with ADHD. In children with ADHD, the symptoms are more or less persistent. Something which is very important is that frequently oppositional defiant disorder or conduct disorder and ADHD can also be present. They may coexist. And when that occurs, DSM says that we should diagnose both disorders. We must also distinguish specific learning disorders from ADHD. A child may be unable to read or do mathematics because of a learning disorder rather than because of inattention. So we should not only focus on the child's attention, but also if the child is having any SLD. ADHD may often coexist with one or more of these learning problems, and including deficits are in reading, mathematics, or in written expression. Now, what is the course and prognosis of ADHD? The course is variable. Symptoms persist into adolescence in 60 to 85% of cases. And this is from Kaplan, and into adult life in approximately 60% of cases. The remaining 40% may remit at puberty or in early childhood. In some cases, the hyperactivity may disappear, but decreased attention span and impulse control problems persist. Overactivity is usually the first symptom to remit even after medication, and distractibility is the last. ADHD does not usually remit during middle childhood. A family history of disorder predicts persistence, as do the adverse life events and comorbidity with conduct symptoms, depression, and anxiety disorders. When remission occurs, it is usually between the ages of 12 and 20. In about 60% of cases, some symptoms persist into adulthood, inattention being the most common symptom that persists. Children with ADHD whose symptoms persist into adolescence are at a higher risk for developing conduct disorder, and those with conduct disorder are at a higher risk for developing substance use disorder. Overall, the outcome of ADHD in childhood seems to be related to the degree of persistent comorbid psychopathology, primarily and most importantly, conduct disorder, oppositional defiance disorder, social disability, and chaotic family factors. For optimal outcomes, it is extremely essential to ameliorate child's social functioning, diminish their aggression, and improve family situations as early as possible. Now, when we talk of pharmacotherapy in ADHD, there are extensive guidelines for the pharmacotherapy. There are two types of drugs. There are stimulants and non-stimulants. The stimulants approved by our FDA are methylphenidate and amphetamines. We'll straight away skip to the stimulant medication. Methylphenidate and amphetamine preparations are dopamine agonists. However, the precise mechanism of their action, central action, remains unknown. They are highly effective in up to three-fourths of children with ADHD with relatively few side effects. Some children experience a rebound effect when we start them on methylphenidate, in which they become mildly irritable and appear to be slightly hyperactive for a brief period when the medication wears off. In children with a history of motor tics, we should observe them, as in some cases, methylphenidate can exacerbate the tics, whereas in other children, the tics are unaffected or even improved in some cases. Because tics wax and wane, it is essential to observe their patterns over a long period of time. Another common concern with the use of methylphenidate is potential growth suppression, which is there in prolonged use. There is also headache, stomachache, nausea, and insomnia, and often we see decreased appetite in children. Next is dextroamphetamine or amphetamine salt combinations, which are usually the second choice when methylphenidate fails. We are not talking much about the amphetamines because, according to the IPJ, they are not in the plan for treatment for ADHD. The non-stimulants which are used are atomoxetine, bupropion, clonidine, and guanfacine. So, atomoxetine HCl is a norepinephrine uptake inhibitor approved by the FDA for treatment of ADHD in children which are 6 years of age and older. The mechanism is, although it is not well understood, but likely involves the selective inhibition of presynaptic norepinephrine. The most common side effects include diminished appetite, which is the most common, which is noticed clinically as well. There is abdominal discomfort, dizziness, and irritability. In some cases, there is increase in blood pressure and heart rate. So it, as a rule, it has to be monitored. The second is alpha agonist, both short acting and extended release forms of clonidine hydrochloride and guanfacine. Clonidine, more commonly used, are FDA approved for the treatment of ADHD in children and adolescents from 6 to 7 years of age and above. Clonidine is a centrally acting alpha 2 adrenergic receptor agonist, likely exerts its effect on the prefrontal cortex, although the mechanism of action is unknown. The extended release guanfacine, not used in India, is once a day medication for children between 6 and 17 years of age. Bupropion is somewhat useful for some children and adolescents in the treatment of ADHD. One multi-site double-blind placebo-controlled study found a positive result regarding the efficacy of bupropion, although it is not FDA approved, but it is still used in some cases. The higher risk of seizures is on doses 400 milligrams per day or above. A few data confirms the efficacy of SSRIs in the treatment of ADHD, but due to the frequency of comorbid depression and anxiety, in case of comorbidity, they are likely to be considered at least in a conjunction with a stimulant. We should absolutely not use tricyclic drugs for ADHD due to potential cardiac arrhythmia effects, and antipsychotics may treat refractory or severely hyperactive children and adolescents who are significantly dysfunctional, specifically in children with a lot of aggression. When we come to the dosage, in methylphenidate, the dosage is usually 10 to 60 milligrams. 60 milligrams is the maximum. For atomoxetine, less than 70 kg, it is 0.5 milligrams per kg per day for the first 7 days, then 1.2 milligrams per kg per day, and then it is 1.8 milligrams per kg per day. The maximum is 120 milligrams. For children more than 70 kg, children or adults more than 70 kg, we start with 40 milligrams per day. After 7 days, we make it 80 milligrams a day, and we can increase it to 120 milligrams per day. But I repeat, the maximum is 120 milligrams per day. For clonidine, we can start with 100 micrograms per day. Again, 100 micrograms is 0.1 milligram. After 7 days, we titrate and increase the dose to 0.2 milligrams per day, and maximum dose is 400 micrograms, that is 0.4 milligrams per day. The common side effects with clonidine are somnolence, fatigue, reduced BP, reduced heart rate, and abdominal discomfort. Now, monitoring pharmacological treatment is extremely essential because some drugs like methylphenidate have increased tics, they have growth restrictions, there is decreased appetite, and atomoxetine increases the heart rate, BP. It is cytochrome P2D6 inhibitor, and it also has a black box warning with increased suicidal thoughts. So, monitoring is extremely essential in pharmacotherapy. Stimulants have adrenergic effects and they cause moderate increase in blood pressure and pulse rate. Physical examination, blood pressure, pulse, weight, and height should be done on every visit. Screening ECGs are recommended prior to initiating stimulants, particularly if there is a family history or risk for cardiac disease. Children and adolescents using stimulants should have their height, weight, blood pressure, and pulse checked quarterly as well, even if they are not visiting, and have a physical examination annually. Monitoring starts with the initiation of medicine itself. Now, what are the psychosocial interventions? Because pharmacological management is one aspect in ADHD, but psychosocial intervention is a huge part of management in ADHD. In non-pharmacological, that is psychosocial intervention, we tackle three things. The first is parent, the second is what we do with the child, and the third is what we do with the school liaison, that is the teacher. So to parents, we do two things. First, psychoeducation about the illness is extremely important for parents. False promises should not be made. The second is behavioral intervention techniques. We have to identify the problematic behavior. We have to form, organizational skills. The parents should be taught about positive reinforcement, negative reinforcement, and punishment, rewards, Primark principle, timeout technique. It will help parents, discipline children a lot. And to parents, we should teach stress tolerance. For children, we should, in therapy, what we should do is attention enhancement exercises, the black dot meditative technique, then the Jacobson's muscle relaxation technique. All of these attention enhancing exercises should be performed. Social skills training should be done by a clinical psychologist, and anger management should be taught so that it doesn't lead to conduct and oppositional defiance disorder. In school liaison, it is extremely important to be in touch with the teachers, even while assessing. It is important to be in touch with the teacher. And in school liaison, we try to make the child sit in the first row so that the teacher is also paying attention to the child. Clear instructions should be given to the child because usually multiple instructions, organizational skills, DLPFC is inactive. So if we tell them to, open this book, this page, this paragraph, this line, the child gets confused. So we have to give clear one by one instructions. The teacher has to be taught to do this. The school has to be taught. Then repeated context of the topic. The child requires probably repetition of the topics because of inattention. They tend to skip out. So the teachers and the school should be told that repeat the context of the topics as well. And a study buddy helps the child a lot. If you give them a seat partner and a child can explain them as well. So a study buddy will help a lot. So non-pharmacological management, it is a huge basket in which there is psychoeducation, there is behavioral modification, the child therapy is there, parental therapy is there, and school liaison is also extremely important in psychosocial intervention of ADHD. Now, when we talk of the goals of management, what are the goals of management when we are talking of management in ADHD? The short-term goals of management are, the first is symptom control, whatever symptoms the parents have brought the child with. Second is we should improve the school performance, raise the self-esteem of the child, because if we do not, that can lead to depression. As we saw, it's a comorbidity. Reduce the risk-taking, I'm sorry for the spelling mistake, reduced risk-taking ability in the child, and better peer relations, that is social skill training, should be there. Again, when we talk of long-term goals, 3 long-term goals are good, better interpersonal relationships, reduced physical and mental morbidity, and better academic performance for the child as well. Before we talk of only the IGP plan, we will talk a little bit about the treatment guidelines. So there are two types of guidelines. One are Western guidelines and Indian guidelines. Indian guidelines are IAP, that is Indian Academy of Pediatrics guidelines, and IJP, which is the Indian Journal of Pediatrics guidelines. In the Western guidelines, there are NICE or Maudsley guidelines, which say that if the child is less than 5 years of age, the first line should be behavioral intervention. And if the child is above 5 years of age, medication plus behavioral intervention should be done. The first line of treatment is methylphenidate, and after 6 weeks of adequate dose, or if there is increased tics or growth retardation, we shift them to atomoxetine. And the second guidelines are American Academy of Pediatrics guidelines, which were updated in 2019, while the NICE guidelines or Maudsley guidelines say that above the age of 5 years, the medicine should be given. They say that it is above the age of 6 years that behavioral therapy and medication both should be given. And less than 6 years of age, it is only behavior therapy. When we talk of IAP or Indian Academy of Pediatrics, they again say that less than 6 years, behavioral, and more than 6 years, behavior plus medication. Now, IGP plan, which is followed most commonly, they say that the first line, no matter what, should be psychoeducation and communication with the parents. Again, if the child is less than 6 years, psychosocial intervention should be done. If the child shows good response to psychosocial intervention, maintain periodic review. And when the child is of age, when the temperament is developed, start them on cognitive behavior therapy to control mild anxiety and depressive symptoms. And if the response is inadequate to psychosocial intervention, assess any comorbidities or non-compliance to the psychosocial interventions. Again, assess the response. If the response is good, follow this. And if the response is still not good in a child less than 6 years of age, we can start with medication. If the child is above 6 years of age, IJP says start with medication directly along with the psychosocial intervention. And again, you can start with methylphenidate and after 6 weeks, change to atomoxetine or clonidine. According to the Indian plans, amphetamines are not prescribed in children. So we follow the rules of first giving methylphenidate and within 6 weeks, shifting to atomoxetine, considered that the child has no increased tics or growth retardation. Now, before we finish off, we can talk a little bit about the modern topic, that ADHD in adults. We all have a lot of adults coming to us and telling us, I think I have ADHD. So how do we make a diagnosis in such adults? The first is that the diagnosis of ADHD is retrospective in adults. We have to take a complete history. We have to take the childhood history. If possible, we have to take history from parents and also see if all of those symptoms, the 9 symptoms of inattention, 9 of hyperactivity, 6 out of those were present during the childhood. If the child had any oppositional defiance or conduct disorder, and it is best to take that history from parents. And again, the diagnosis is retrospective. Second is if there is evidence of onset in the childhood, there is a UTA criteria, which is the UTAH criteria, and it gives diagnosis. It makes it easier. If 5 out of those 7 symptoms are present, then we say that it is, the person might have adult ADHD. So it helps us in the screening of ADHD. Or second thing that we can do is, in the OPD, what we can do is we can assess inattention and hyperactivity. If 3 out of these 5 things are present, retrospective diagnosis along with inattention presently, along with hyperactivity presently, there is disorganization, impulsivity, irritability, impaired stress tolerance, and mood liability. If 3 of these 5 things are present, then we say that the adult has ADHD. Now, in management of adult ADHD, we say pharmacological management is first line and non-pharmacological is second line. So again, the first line is methylphenidate. Although Stahls says that methylphenidate has abuse potential, so they prefer atomoxetine, but there are no certain guidelines right now. Now, when we talked of ADHD, the last thing before we end is that we talked of ADHD with ODD, that is oppositional defiance disorder, ADHD with substance use disorder, and ADHD plus tics. So if there is ADHD plus tics, we prefer atomoxetine. If there is ADHD plus ODD, the studies have shown that clonidine shows a better response as compared to atomoxetine. So all in all, this is about the biology of ADHD, the neurophysiology of ADHD, diagnostic guidelines, changes made in the DSM, ICD-11, the diagnostic criteria, the comorbidities, management, both pharmacological and non-pharmacological management, along with the guidelines and a little bit about adult ADHD. With this, I end my presentation, thanking you all for your patience. So I think I will tell them to take over.
Thank you so much, ma'am, for this wonderful session, ma'am.
Ma'am,
Welcome,
there
you're most welcome.
are questions are there in the chat box also. There are some questions in the
Yes,
chat
yes.
box.
I was just opening the chat box. So when we talk on how to differentiate between autism spectrum and ADHD, one thing is, the scales help us a lot. The assessment tools, they help us a lot. So autism spectrum, and sometimes also, ASD has a lot of aggression. So in that aggression, we confuse that with ADHD many a times. But there are some clear-cut symptoms, in children with ASD. Something that we notice very commonly in the OPD is that, the child is not that hyperactive. One thing which is very common is they don't want to wear the slippers. They are lost in their own world. So some pinpoint the parents will give us. In ASD, the parents usually say that, ye bacha apni hi duniya mein hai. They are in their own world. While children who have ADHD, they usually are reliant a lot on their primary caretakers. So the mothers are always running around them. And again, the repetitive behaviors in ASD, they give a lot of direction to the diagnosis. When we talk of play, they love playing with water, which is, again, clinically it helps us to differentiate, which is the first assessment that we should do. Ideally, clinically, we do the assessment usually both ADHD and ASD in children if we are doing it. But again, after this clinical differentiation, how the child is playing. Does the child love playing with water? Is the child willing to wear clothes, any clothes that the mother is giving them, or do they wear really soft clothes? Do they observe the movements of the fan? Are they easily distracted by or concentrate on the voice, little voices like the voice of the fridge? We can ask them if the child likes to brush their teeth, because all of these problems are usually not seen in ADHD. If all of these are there, it points more towards the autism spectrum. So this history helps us determine if they have ASD or ADHD. Also, when we talk of their toys, they what part of the toys do they play with? Whatever they are given, if they are given the building making blocks, they arrange the blocks in a line, they arrange the cars in a line. They keep, if they are given a truck, they keep playing with the tire of the truck. So all of these little things, they point more towards ASD and less towards ADHD. And ADHD, though, the symptom checklist is quite extensive, as was told, the hyperactivity and inattentive checklist. And how long can we give stimulant? According to the guidelines, it should be changed after 6 weeks. So methylphenidate for 6 weeks. In all of the guidelines, it is static that it has to be changed after 6 weeks. What is the duration of pharmacotherapy? And role of screening tools, I think I just mentioned the role of screening tools. I personally, Vanderbilt assessment is very good. It has both teacher and parent assessment, and it helps us, and it is not very time consuming as well. Brown and Vanderbilt assessment scales, we always depend upon scales for the optimum diagnosis, so they are great. The duration of pharmacotherapy, usually we try to taper that down along with the psychotherapy within 6 months of age. But in some cases which are really resistant, we have to give them for a prolonged period of time. Although according to no guideline, there is a certain period of time for which this has to be given or it has to be changed. How must behavioral and pharmacological, how often must we reevaluate the symptoms? At least once in a month. But if the child is visiting you more often, then then I think it is best if we assess, reevaluate the symptoms, because in the Vanderbilt scale, there is an extensive checklist. We get to know if the child is more inattentive, more hyperactive. And when we are in liaison with school, it is better to give updates to the school as well. So we know what is working and what is not. If we do the assessment after 6 months or 1 year, then we do not know that what part of therapy or what part of medication worked on which symptom. So the earlier the child is reviewed, it is better. So I think that is about it in the chat box. If there are any more questions,
If anybody has
free to
any
ask.
question, please ask. Or we can close this session.
or if anybody has a good case with
It was good.
ADHD, I think it will help
It was
us a
really
lot.
fantastic, ma'am. It was really fantastic. And we have shared this link over YouTube also. So people can go over YouTube also.
Great.
The link is already there. I have shared the YouTube link also. So the whoever wants to see this lecture also, they can see it also.
There
this
is
is
also
really
another
fantastic,
question in the chat box, that are amphetamines available in India? Although amphetamines are available in India, but according to the IJP plan and the IAP plan, amphetamines are not approved for ADHD. So I think they are under the process of doing that. But amphetamines are not approved for ADHD, even in adults in India right now, probably because of the abuse potential. But they are currently not approved. So even if they are available, whoever is using them are not, it's out of the guidelines that they are using, or maybe doing it in resistant cases. If anybody has any experience with the use of amphetamines in ADHD, they can let us know, because I personally have never used it.
Thank you, ma'am. Thank you for replying all the questions, ma'am, especially.
Thank you.
It is really a pleasure to have you on this desk, ma'am.
Thank you.
Anybody wants to ask any question, please ask. Even some of the doctors are still joining, ma'am.
Yes, I was also just seeing that some are still joining.
Maybe they get free just now. So,
Some don't even get free till now.
OPD, ma'am.
Yes,
OPD goes even 10 p.m. or 11 p.m. also.
absolutely.
Hello.
Yes, sir.
Very informative talk by madam, and we have learned many new things from madam, and we hope that we have such program in future also.
Sure, sir. Sure. Thank you,
madam.
sir. Thank you, Satish, sir. Thank you, Satish, sir.
Welcome.
Okay, we will wind up this session, ma'am. And thank you for giving your time, ma'am. We'll
Right.
do this type of lecture again also in future, ma'am. We plan further more webinar, ma'am.
Great. Thank you.
Thank you, everybody. Thank you so much for joining, ma'am.
Thank you.